Hi, good morning, good afternoon, and good evening. This is the third day of 8th Texila World Conference for Scholars under the theme Embracing Environmental Change and Transformation, Breaking Innovation and Creativity, Leading Change, Re-engagement. This is the third day. We start with the same quote: innovation distinguished between a leader and a follower. Knowledge increased by sharing and not by saving. Knowledge is power. Knowledge shared is power multiplied. An investment in knowledge always pays the best interest. So here we are going to start a session 1. Dear Excellencies, distinguished delegates, scholars, and scientists, it's my pleasure to be the session chair of the day. My name is Rakesh, and on behalf of Texila E-Conference, I would like to extend a very warm welcome for the 8th International Scientific E-Conference. Texila E-Conference is conducting conferences for 9 years in a row. Texila has made revolutionary the way scholars attend academic conferences and has attracted more than 8,500 participants in 80 plus countries. Texila E-Conference stands in the front row, conducting virtual conferences, saving your valuable time, money, and guarantees the comfort you require. The topic for this year: embracing environmental change and transformation, breakthrough innovation and creativity, leading change, re-engagement. The primary reasons why we selected this topic is change is difficult to accept for everyone, but change is constant in life. In a universe that is subject to a state of constant entropy, change is inevitable. No matter how hard it is, we will have to work through the changes in our life and make best out of them. In the recent past, COVID-19 brought the world to a standstill and changed everyone's life. But humanity has found a way and is working towards a better tomorrow. Embracing the changes that surround us in the first step towards innovation. Without change and innovation, humanity would not be what it is today. The COVID-19 pandemic forced us to innovate. The crisis that changed everything altogether gave rise to opportunity to innovate and benefit from it. Those who reacted to the problems with creativity reap the benefits of their innovation. The world saw massive innovation in medicine, technology, public health, logistics, etc. Development has been manifold in the past 2 years. Embracing the change and innovations are what transformed how the world runs. Learn how embracing a change can help with creativity, innovation, and constantly transformation. So Texila E-Conference is a wing of Texila American University. Texila American University has been developing a great minds in the field of medicine, public health, information technology, nursing, and business management for more than a decade. Represented by a tradition of innovation and research, we are breaking new grounds, pushing forward the boundaries of knowledge and making an impact in our students' lives. We wish to continue this tradition for a future that will define our work and recognition at the international stage. We have our own campus in both locations, Guyana as well as Zambia. So Texila American University is a private medical university in Guyana, South America. Guyana is a country where the Caribbean meets South America. That only English-speaking country in South America is known as its lush and thick rainforest. Texila Medical School in Guyana is one of the fastest growing and well-recognized medical college in Guyana and listed in one of the top medical Caribbean schools in the country. The constantly evolving healthcare needs of the world can only be addressed by expert medical professionals with sound knowledge and competent skills in their field. To meet this growing demand, Texila American University College of Medicine offers its medical degree programs in the Caribbean. Also, we are offering College of Business Management for the management programs and College of Public Health having the public health programs, both in master's and doctoral levels. Texila World Conference Zambia is one of the most sought after private medical schools and is known its state-of-art infrastructure and up-to-date curriculum designed to craft world-class doctors and healthcare professionals. With the education system built to international standards, we are committed to provide our students the exposure and guidance required to excel in a competitive global ecosystem. An intensive medicine and healthcare program combines theoretical knowledge and practical experience to prepare leaders for tomorrow. We have a different streams in the Zambia campus also. We have public health, management programs, nursing, international information technology, and other health allied sciences in both master's, doctoral, as well as bachelor programs. On behalf of Texila International Conference, we thank our beloved partners, Texila International Journal, Confiogo, Blue Crest University College, Indian Journal of Scientific Research, Journal of Pharmacovigilance and Drug Research. Before I conclude, dear all participants, I want to share a few operating instructions for to follow. All participants should check your speaker settings to make sure the presentation is audible. Those who are making presentation, please enable your mic from the toolbar at the top and share your webcam by clicking on the start webcam on the sidebar. At the end of each presentation, there will be a Q&A session for 10 minutes wherein you can post your questions and it will be answered. So I may request the first presenter, Mr. John Musonda, on the topic Private General Practitioners Agreement on Skills and Competencies for Universal Health Coverage in Urban South Africa, a descriptive cross-sectional survey. I may request John to talk something so that I can check the audible here, voice.
Yes, good morning, good afternoon, good evening.
Thank you so much, Mr. John. Can you share your screen so that I can confirm that too?
Yes, my name is Dr. John Musonda. I'm a family medicine physician and also a faculty member of the University of Witwatersrand, Department of Family Medicine and Primary Health Care. I'm involved in supervising undergraduate and postgraduate family medicine. I'm also quite active with hospital management as hospital director across the 6 hospitals I'm looking after, and coordinating the district clinical specialist team, as well as I'm the COVID-19 vaccination lead for the district. Currently, just about to complete my PhD with Texila. I'm privileged this morning to share a mini study with you. This mini study is part of the bigger study for my PhD, which looked at exploring the development of family medicine in readiness for the universal health coverage for urban South Africa. And in that whole thesis, there are a few studies, and this is one of those, one of the many studies. You can see that investments in stronger health systems promote and protect economies. It protects businesses, protects peace, protects livelihood, sustainability, general equity, and promotes the environment, promotes education, and many more. I will first start with the nomenclature that general practice, if you say general practitioner, there are 2 forms of them. There are those who are general practitioners and working in the public sector, and also general practitioners who work in private sector. I think every country on the continent as well as in the world has got a private sector aspect to it. In other economies, these are blended and managed together. In other countries, these are quite separate. In South Africa, as the case, the private sector and the public sector are quite distinct. You know, they are separate, and therefore our study looked at focused in this case. This mini study focused on the private general practitioners. I will first, in terms of nomenclature, the World Conference on Family Physicians of 2008 in Rustenburg, South Africa, did define who a general practitioner is, and the family doctor and the family physician. A general practitioner is in our context in South Africa is somebody who's completed the medical training and goes into private practice. So it becomes a private general practitioner. Those who just completed the medical training and join the government and work as a generalist, meaning you are rotating in all disciplines of medicine, of clinical medicine, those are called the public general practitioners. And they are also called the family doctors in our context. But also in other parts of the world, if you talk about, and then a family physician in South Africa is somebody who's done 4 years training to become a family physician, is really an expert in primary health care. And those also are family physicians by virtue of their training. They do general practice work, but at a much more advanced level because they've got the additional qualifications. So in this context, then we are looking at the private general practitioners who are not trained. But in our survey, we also included the family physicians who are in private practice, so that the understanding is clear. All right. So the globally, Sustainable Development Goals and universal health coverage are premised to ensure equity and quality health care. In South Africa, national health insurance is the intended vehicle to achieve the health care, the universal health care. Remember that these development goals 2030, you know, goal 3 talks about you know, issues of health coverage, and also alludes the fact that there should be a universal health coverage in order to protect people's finances and ensure there is equity in healthcare. So when you talk about the universal health coverage in our setup and the national health insurance in this aspect, because in South Africa, our tool for achieving a universal health coverage is through national health insurance. And with it, the strategy is that we are going to purchase services and by contracting general practitioners. That is key in that we need to identify where these general practitioners are in the community, and we need to strategically purchase their services, which could then be paid for in a central pool. And with that, the skills training will prepare GPs. However, it is not clear yet which GP skills and competences are currently in practice. So in a readiness for the NHI, it would be prudent to look at which skills are currently there and where gaps may exist. So then the study assessed the GP's agreement on the core clinical skills and competences in urban South Africa and readiness for the NHI. When we talk about clinical skills, we talk of the easiest way to understand it is we're talking about procedures, clinical procedures. These could be examinations or special procedures which are done. And when we talk about competences, we're really talking about the scope of practice. And there are key elements we look at under competences as well as the clinical skills. Yeah, so then as a summary, this was a descriptive cross-sectional study which used the online semi-structured survey, which from 3rd September to 14 October. we targeted the 5,212 private GPs registered on MediPages in Gauteng, South Africa. After a simple randomization, we managed to invite about 2,780 to the online survey. Remember, the context of this is that this happened at the height of the COVID, when most of us were actually indoors. And we took it as an opportunity to send out a survey so that when people were at home, they could probably, the GPs were at home, their practices were almost closed. Most of them were closed. They were trying to learn to do teleconsulting and telemedicine, but it was not that developed. So it was at that height that we did that. In a private sector provides a large share of health services available in any country. The general practitioners then constitute, in most institutions, they constitute about 10% of medical profession worldwide. And it's very useful. They normally congregate in urban areas and provide many curative services because they are private practitioners. Their services are available to those who can pay. That's why they are in private. Payment becomes an issue. And often it is not very organized. And some statutory bodies regulate private medical practitioners. Yeah, they should. Almost all statutory bodies across the world, they try to regulate private practice. But that is what it is. It's about payment, and if you can't pay, then you can't use them. So access is an issue. So under universal health coverage, we want them to be part of the solution. And again, we used a four-point Likert scale, which was categorized into, we had the strongly agree, strongly disagree. And then we aggregated these, or categorized them as agree and disagree when we were analyzing. A word chi-square test evaluated associations between variables. We found majority agreed to skills such as the eye, ear, nose, and throat skills. And the least agreeable was the abdominal skill. All competencies were generally agreeable in the excess of 80%. Logistic regression, short codification, work experience, and type of practice were significant predictors of agreement. This is important, but the conclusion, GPs did not agree to listed skills. Significant predictors of agreement were assessed and identified. Findings highlight the need to fast-track GP training readiness for NHI in South Africa, and we could actually extend this to elsewhere where the NHI is being implemented. So the Learning Needs Survey started. The Learning Needs Survey and the two national stakeholder workshops were conducted in South Africa in 2016 to align all diplomas and design a national diploma for South Africa. Because of the NHI and the universities, the emergence of the NHI, universities came together and said, let's try and develop a national diploma for family medicine, and which subsequently identified the roles and competencies for primary care doctors. It was envisaged that under the NHI, majority of primary care doctors, they were the GPs, who provide private GPs, especially in the urban environment. While rural needs were important, the urban settings would be increasingly greater and more of the norm. Because of this rural-urban movement or migration, we still think a lot of people would be, even with the NHI, if we do not do deliberate effort to look at it, a lot of rural people be coming to hospital and to urban areas and find the GPs will be more overwhelmed there. Private GPs may be disinclined to do a course that may perceive unsuited to the needs of an urban setting. So because we want to know what skills are at present there, so that when we do design a course, it would be what they would be expecting to use. They would find it useful. So what we already knew was that the implementation of universal health coverage required strengthening of primary health care through GP skills. So that is from literature, we knew that we need GP skills to be up to the scratch in order for the primary health care to be strengthened. And we also know that there was a consensus on core clinical skills which were listed in the learning outcomes for the family medicine diploma. So we had achieved the consensus list of learning outcomes, which are the skills and the competences. So we then, as a prelude to the above, Malan conducted a study in 2015 in South Africa to evaluate the self-reported learning needs of primary healthcare doctors among 30 guidelines, 85 skills, and 12 roles. This document is what formed the basis of our tool. It was the 30 national guidelines. Yeah. The 30 national guidelines, and they identified the 85 skills and 12 roles were used and adapted to develop a list which we used to evaluate the current practice for the private general practitioners. In this study, it was a descriptive study which they conducted with a convenient sampling of 170 private GPs and medical officers from 8 provinces in South Africa then. The 170 private GPs were invited specifically across the country to come to Pretoria, headquarters of South Africa, to come and be oriented on the national health insurance and such aspects, because the contracting of general practitioners first needed to share that kind of information. So then Malan and the team, they used this opportunity to survey those who had come, and they then came up, compared with the previous studies which were done and the workshops of stakeholders, to identify what will be on the list of the national outcomes in the diploma for South Africa in family medicine. So then what is the issue? Private GPs are seen to function suboptimally in the private sector in South Africa. We say this because it's evident from reports in the press, it's evident from the other forms of media, social media, and all that. And they function suboptimally, yet the country faces the quadruple burden of disease. We still have a high prevalence of HIV and AIDS and TB, high maternal and child mortality, non-communicable diseases, violence and injuries that constitute the public mandate for care. This is where most of the public purse is spent. When you look at injuries alone, in South Africa, every holiday, Christmas, Easter, and such kind of holiday, you've got over 1,000 mortalities in the road traffic accidents. You know, it's just causes so much burden on the public finance. And with all this background in mind, we need then to know how to handle the issue of GPs performing suboptimally, because the context is a very complicated one. So despite the knowledge gap, there is currently no training pipeline adequate to meet the private GP needs for the new health system. Here, what we are saying is that the mandate in terms of the GP training is still up to now optional. The diploma course, national diploma course, which is there, which should really be a bridge between being trained and not trained, between a general practitioner who just come out from medical school to a family physician who's been trained. So there is no formalized way of engaging all GPs to undertake that training. So then the NHI itself could then be used as a potential springboard to address that gap by accelerating skills acquisition. Purpose of was to evaluate GP's agreement on core clinical skills and competencies in the current practice as listed in the national document on family medicine diploma in South Africa. The aim was to assess private GPs' agreement to core clinical skills, and the objectives were to describe the social demographics, agreement on skills, and associations between skills and demographics. Then we undertake a descriptive cross-sectional online survey at the height of COVID, and then we also used using MediPages database. We targeted 5,212 registered GPs. MediPages database is a database where all general practitioners and the specialists of different types are registered across Africa, so that if you want to, they keep that kind of database about their contacts and qualifications and so on. So that it's a very big resource in terms of research. It's a MediPages database. So from there, we worked with them, and obviously it needed to pay fees, and needed certain regulations to be met. Then they managed to, not manage, they assisted to sample. Using a simple randomization, they managed to invite on behalf of the researchers 2,780. We prepared all the documentations in terms of consent, research, the questionnaire itself, as well as all the relevant information and approvals and the ethical approvals and so on. So we then surveyed these 2,780 between 30 September and 14 October 2020. We emailed the questionnaire, consent form, and developed a survey platform. We needed a platform for us. There are different platforms available. You can use the Red Dot. You can, if you want, you can use that, or you can use the other forms of surveys. But in our case, we used the SurveyMonkey, which we found quite useful to analyze the things on the spot as we went on. And the tool we used to develop the questionnaire was a validated one, used, as I said, in the area study by Melan and the team. Respondents who completed the questionnaire in full. We do not want people just responded, but gave us didn't sign the consent, they just clicked through and all that. Those we sort of took them out. There are those who signed the consent and started doing the questionnaire, which had the 20 or so questions, 25 questions, and took semi-structured, took about just under 5 minutes to do. You could do it on your phone, or you can do it on your laptop. So it was actually quite useful to use. So then we saw that about 162 did consent, and they started completing the questionnaire, but they did not complete it in full. So we took them out and conveniently worked with what was those which were full completed questionnaires. A 4-point Likert scale was categorized, as I said, from agree and disagree. A word square was used. Odd ratios with a 95% confidence interval and p-value of 0.05 were considered significant. Ethical considerations was obtained from University of the Witwatersrand, Human Research Ethics Committee, and 4 District Research Ethics Committee in Gauteng. The MediPages made sure that they invited private practitioners from across Gauteng. So the simple randomization meant that they had to match regions and the numbers of general practitioners from there who were to be invited. And proportionately, depending on how heavy the region was, Gauteng has about 5 regions or health districts. And the heavier ones, we invited more GPs than in those which were less heavy. And the reference number was M, which is medical, I think medical research, 181111115, a quadruple 15. And then the National Research Database number was also GP 2019-0302 and 1 in brackets. Before just to obtain ethical approvals here, it was a tall order in that Out of those regions, 4 of them were the district health ethics committees, where we also needed to get a separate ethical approval before the university could approve, actually. And then we also had the national one, where we also registered and got that number. So it's also in the national database. So this administrative work was quite time consuming and it needed space. Results, quite a bit slide there, but we probably can see table 1, social demographics. The mean age of respondents was 49.5 years, and the respondents were aged between 27 and 79 years old. Imagine we still have, we still have 79 years old who are in full practice, and males were 53 and they were white. Those were the typical participant. This was the typical participant. It was a white person who was a male between that age, and the mean was 49.5. You can see that maybe it can tell you more in terms of culture and all that. The majority of the doctors in the country are actually black doctors, but when it comes to surveys and all that, they rarely participate. And this is what we did. The age, the median 49, minimum 27, maximum it was the male, female. Yeah, so this is what transpired. Then when you look at those who had at least some qualification, certificate were 27 or 23.5%. I think that was like the highest there. Those were in group practice, 32%, solo practice, 61%. So most of them worked in solo practice. And yet the NHI and the contracted GPs, we want them to work in group practice. So this informs us that going forward, general practitioners must be encouraged to work in groups, because we're encouraging them to be in group practice. And then we can also, when you look at that is table 1, very busy slide. Then table 2 looked at list of skills. Yeah, the skills were, for us to have all those 85 skills and all that, the skills at general medicine, abdomen and the GI skills, chest respiratory, antenatal, intrapartum, postpartum, women's, pediatric, general surgery, orthopedics, emergency care, skin health, forensic, clinical administration, communication. When you look at the responses, total responses is 7,117. Each question had different responses given, but we worked all of it out of 100. In order to compare them, we worked as a percent out of 100. Although they are each question has a different response, they can only be compared if we do it in percentages. That's how we worked out the percentages. And when we talk about general medicine, for example, or chest and respiratory medicine, we look at commonly used procedures under that. For example, under chest respiratory, there are X-ray interpretation. There were also a list of criteria or elements we need to look at under each. Like, for example, chest, the issues of chest X-rays, issues of peak expiratory flow rates, those kind of procedures. The general medicine itself could have how to interpret ECG and such kind of things. Surgery had something like how to do an IND, ear, nose, and throat, same, it had how to examine. The things you do at primary healthcare level, that is what we looked at. So these were the list, the skills which are on the list. And you find that the eye, ear, and nose, they were a combined skill. They were they were really agreed to this skill, which suggests that they were probably not doing it well, or they were having problems with the referrals. Hence, they want to that this skill could be seen as relevant in their current practice and going forward. The skills which were less agreeable, postpartum care, antenatal care, forensic. When you look at the postpartum care, it's also related to antenatal care and also to maternity itself. GPs are not very comfortable doing this. I think the reason being that they could be, they could risk medical legal problems. So because of that, they really didn't like this kind of skills to be done in their practice. The least agreeable was the abdominal skill. Under abdominal skill, there was the rectal examination, proctoscopy. They didn't like this because I think they thought it would do, it needs special preparations and environments. Competencies, in terms of competencies, we normally look at the competencies we look at mainly the six, there are six. You know, in the study which was done, they did 12, but these were combined to make it 6. And these 6 are the ones we look at in terms of outcomes for the diploma course, as well as postgraduate family medicine training. To be a competent clinician, so to be, this is more of a scope, as I said, these are the list of competences. To be a competent clinician means you need to have broad and multidisciplinary kind of skills. And this only comes if you work in a district hospital for many years. Then you'll be able to give anesthesia, you'll be able to give to do cesarean sections, you'll be able to do INDs, the shoulder dislocation, you'll be able to reduce dislocations, you'll be able to do simple obstetric procedures and all that. So you need to be a competent clinician and also a change agent. You know, this conference is talking about change. Change as the only constant in this life. We change all the time. So as clinicians and general practitioners, we need to be change agents in terms of implementation of national policy, as well as the participating and working with the community and changing them for the better in terms of healthcare, empowering them and all that. You need to be a critical thinker, analyzing lab results, analyzing trends, analyzing the epidemiology, the stats. You need to be a capacity builder in that you should be teaching, you should be empowering others. You need to ensure that there's some form of continuous professional development in your practice. You have to keep updated. You need to be a collaborator, you know, somebody who works with others, networks, you know, as a principal of family medicine. And you need to be an advocate for the community involvement and participation. So these are the things we looked at, and there are the elements under there in the full tool. It showed who a competent clinician is. So when we looked at this, we found that all the listed competencies except one were agreeable to GP's practice. In responses were more than 80% across, you know, and the only one which they didn't feel they were doing enough was the community advocacy, you know, where we then need that when we do plan our training, we need to really emphasize that there is an element of community participation. Then in terms of associations between the skills and the type of private practice, because these were the ones which were significant, statistically significant, with odds ratios there, the word chart square, p-value, and confidence intervals. We found that work experience was the most significant predictor of association in relation to using orthopedic skills. So if you had more work experience, you were probably very good at the orthopedic skills. So when you plan training, the more experienced people, you sort of will not dwell too much on orthopedic. If you're dealing with the younger ones, you could then spend a lot of time on orthopedic. General practitioners of 40 years and above, 40 years and above of experience are nearly 6-fold more likely to agree to orthopedics. But there was an inverse relationship between years of experience and agreeing, you know, agreeing with the this. So the older you were, yeah, the more likely you were being good at orthopedics. The type of private practice had the most clinically significant association with the emergency care. So those who were general practitioners skill had the highest likelihood of agreeing. If you were skilled in general medicine, you were more likely to agree with emergency in your practice. And group practice were almost fourfold more likely to agree to general medicine skill. So it means that in group practices, they love doing general medicine skills. Probably it's quicker and it doesn't take much time. No, it doesn't need special preparations. So conclusion and future steps, private GPs did not agree to skills listed. Qualifications, work experience, and type of practice were significant predictors to agreeing to a skill. Age was not a significant predictor of agreement. So we didn't see any significant finding in terms of age, whether they agreed with the one aspect or the other. What we saw was that their experience did agree with orthopedic skills. An opportunity exists here for further research and improved dialogue between GPs and government on the NHI. We saw that when you want to develop this planning, there must be a common thinking and the planning, even at the level of government in terms of GP training. They should lead that. So our study reinforces the need to focus on accelerating GP training and readiness for NHI in Africa and elsewhere. We recommend that accelerated GP training should be in partnership with stakeholders and universities. GPs have got a lot of stakeholders, the doctor associations, who are so vocal and they determine what needs to be done. So these are the ones who should be dialoguing with the government as well as support of universities so that we can have a training pipeline for GPs where all the GPs should be able to go through. In South Africa, NHI implementation will be due by 2026. Looking at the way we are going and the impact of COVID on the program, we may not be fully of NHI by 2026 in South Africa. The improved dialogue cannot be overemphasized, and they identified the predictors of agreement to the skill. Work experience, type of practice, and all that can be then used to aid planning for GP training and also the content of GP training. Yeah, those were the top five what you call references. And thank you to healthcare workers and to all of you for listening, but particularly to healthcare workers for their role they have played in the COVID. Thank you very much. I'll end here and take a few comments and questions. Thank you.
Thank you so much, Mr. John Musonda, on the topic presented under the clinical research stream. Dear participants, please raise questions in the Q&A. So I can ask Mr. John to answer on that. Mr. John, we received one question. Your finding indicate the private GPS function suboptimally in South Africa, even though they have a vast list of competencies and skills. Could this be linked to high cost of their services, which deters optimal utilization of their service by patients?
I don't know if I got the question right, but
post this question in the chat box so that you can view on that. Wait 1 minute, sir. Yeah,
I'm trying to look at the questions.
In the chat box.
But the GPs, yes, they are quite. There are quite a lot of GPs who in the private practice, and some of them, even those in government practice, some of them are allowed to work in government as well as to work in private practice if they get permission. But we still have a shortage of doctors in our environment. South Africa's got less than 10 doctors per 100,000 of population in general. It's a large country. We approaching 60 million, and you find that the number of doctors are still few, to the point where the government has been sending some of the students to Cuba to go and train, and when they come back, they are reassessed, they're re-examined, and they're integrated in the system. But also, the medical schools themselves, the numbers have increased. At the time of the study, we had the 8 medical schools. I think in less than 2 years, there have been 2 more additions. So we going towards the 10 medical schools. And the enrollments have also increased. Instead of graduating or enrolling about, every medical school graduates over 1,000, but we want them now to graduate more. You know, we are still very short in terms of doctors on the ground, to the point where we've introduced the middle service health worker, you know, the so-called clinical associates. In other countries, they call them equivalent to clinical officers, which I think in East Africa and Central Africa and the Zambia area there. But in South Africa, they're called the clinical associates, modeled on the assistant physician in the US, and also the way they work in Brazil and Cuba. They combined all those aspects together to have a clinical associate. So that is to help with the mid-level worker to work between a nurse and the physician. So even that hasn't helped much, because we've not opened up more posts for them. So we are still short in terms of numbers. It looks like the resources are huge, but the doctors' numbers are still few. And if you work at a primary health care facility, you'll be seeing like 40 patients a day as a doctor. That is sometimes in excess of 40 patients a day. So you can just imagine the kind of care. So want to move away from that to where we can see our patients well, or see them better. Thank you.
And Mr. John, we received another question. Would more awareness about the issue among doctors start from medical school so that they are up and running what they start practicing?
I see. Yes, you know, thank you very much. The move has been, for that question, the move has been towards strengthening primary health care in the country, moving away from specialist or hospital-centric care to where we offer more promotive, more preventive kind of care. So the resources are being moved from tertiary institutions and quaternary healthcare programs to primary healthcare. And with it, the policies have also moved. In South Africa today, medical interns spend 2 years. They spend the first 1 year in the clinical domains, which are more general of domains, clinical medicine domains, which are like pediatrics, you know, general surgery, internal medicine, and obstetrics and gynae. They spend the first year doing that. In the second year, they spend 6 months doing family medicine, which is a new thing in South Africa. Family medicine, while they are doing that, and they are even interns, are even medical interns, they even come and do their rotation at primary health care centers within the community, so that while they are, before they even start practicing independently, they should see the need for the community, the need, which is the vision of the country. Also, when they are in medical school, there is a program we call Integrated Primary Health Care Program, where all the clinical medicine domains, the main domains, the 4 ones I said, they come together, they join with family medicine. And the family medicine is the one now which coordinates the integrated primary health care program for undergraduates. And this program is started as soon as possible. After they've just had the theories done, maybe in year 3, they start, we call it integrated primary care, IPC, where they start visiting facilities across the country. They visit district hospitals and the community health centers and the clinics. They are based there to spend some time learning about primary health care. So the whole mood is to strengthen primary health care through undergraduate and postgraduate training by looking at this list, which I said, which we've just discussed. And in so doing, we are actually fine-tuning the whole country to ensure that it delivers quality primary health care, because that is what the majority of the population are using. And that is what the WHO advocates, that we need to ensure that we offer our health delivery services through primary health care. It does not stop us from doing specialist and the super specialist procedures and so on. But the majority of the patients, it's a pyramid kind of way. The primary health care is the area where most patients are seen, and then going up to district hospital, then next it should be the regional hospitals, then the tertiary hospitals. So then the resources should also follow where most of the population are. So the country is geared towards doing that, right from training from primary health, training from undergraduates. Yeah, thank you.
Thank you so much, Mr. John.